set the table from a more physiology standpoint. And it's not just electrophysiology, it's physiology. And it just, part of what the confusion is sometimes about electrophysiology is people think, oh, you're just the electrician, you're just going to do the electrical stuff. The entire heart is electrical. The whole concept of hemodynamics is based on electrical activity. And so I tend to think of myself more as a physiologist instead of just an electrophysiologist. And so I kind of push the other guys pretty hard on what are we doing with management of heart failure and post-MI and all the other stuff because of how sort of intertwined you become as the electrician with the physiology of the heart. And so we're going to let's talk about some basic stuff, and I'm going to break down something that you think you know a lot about. All right? So, what the hell is that? You can jump in there, guys. We're going to have to wake up a little bit. I've had my coffee. Come on, Alex.
How was it?
What is it? Okay, it's a sinus beat. So what are the components that we're seeing on the board here? P, QRS, and? Okay. Now this seems oversimple, and you're going to say, man, I think we know this stuff. All right, but then the question is do you know what's happening in each of these intervals? So physiologically, you're going to see this drawn a couple times. So the question is what happens in what is called the PR interval? Where is electricity starting? Where is it going? Where is it going to? Good. So from the SA node, you get a depolarization. You're depolarizing the left atrium and the right at the same time and conducting down through the AV node. And what else? Remember, I'm asking all the structures that are represented for electrical flow through the PR interval. Because everybody likes to dismiss the PR interval. Oh, it's just first degree AV block. You've heard people say that. And sometimes it is just first degree AV block. It is, but to what point does the PR represent? You said SA, depolarizing atrium through the AV, and then where else does it go before you start to see the QRS? Because this will help you define what you're seeing more precisely when you know exactly where the electricity is in the heart at each phase. Through the bundle of His, exactly right. So, God dog, all of a sudden that PR got a little more interesting. Because we not only initiated but left the SA node, depolarized both atria, hit the AV node down through the bundle of His. Now, what does that all encompass in the EP lab? Is that. Now you're going to look at that and say, now what in the hell is that? That look like an EKG. Well, this is the kind of EKGs that I spend time, hours in the lab looking at these tracings when I have a catheter sitting in people's heart. Because what we're seeing then is all of these components and measuring the intervals in between. So this is an A, an H, and a V. And what happens is I come in from the veins here and I put a catheter called a His catheter, or CRD2, octapolar, there's a couple of different things we put right there. And I'm able to see all these signals and then measure those intervals. And again, those are the intervals that are accounting for the PR. So you have your AH and your HV. Now, I'm going to come back to these intervals and we're going to talk about some other stuff, but I'm just kind of putting the foundation down. So that's just the PR. So now the QRS represents what? Ventricular depolarization, exactly right. So squeeze. Now, the important thing to understand about the ventricular squeeze is that we want it to be as synchronous as possible. You've sewn together, nature has sewn together a bunch of New York strip steaks and said, now here's your pump, go. Now, how are you going to coordinate a sack of steak to move blood? It's going to have to happen with some kind of sequence and then coordination. You know, when I'm talking about New York strip steaks, think about the ventricle. The ventricle, when it measures in the left ventricle in particular, you're about a centimeter to a centimeter and a half thick, okay? So that's the little granny thickness cut of a New York strip that the butchers cut up for you at the grocery store. And that's what I'm saying is kind of imagine what it would take to coordinate that. And the idea is with these bundles, is their superhighways to get electricity out to the periphery of the ventricles. Because what you're trying to do is create synchronous squeeze from out to in. That's very, very important, because then we'll start getting into bundle branches and blocks and different things and indications for different devices. Because conceptually, synchronized ventricular depolarization is the best hemodynamic. It's going to have the best hemodynamic consequence. Okay? So QRS is they ride the superhighways out to here, and they start depolarizing from out to in to get your squeeze. And then comes from really what is in the QRS is the T wave. And what does the T wave represent? Repolarization. So right here, within these three blips, is life. That's one heartbeat. You're having about 110 to 120,000 of those a day. So by the age of 70, which is about the kind of average age of the folks a lot of us take care of, I get to quote to them that it's about 3 billion heartbeats to make it to 70. So when you start kind of putting what the heart is doing into trying to gather that information in your head, you realize that this thing is chugging, man, all the time. And how it moves and how you treat it is going to equal how your life goes. Okay? And so that's where things like exercise are important. That's where things like not pumping this, making this pump that was designed for a 150-pound or 175-pound body into a 300-pound body equals wear and tear on this son of a gun. So all the other problems that we see people have are going to impact this pump, because this was designed for, whether you like the BMI charts or not, your average body size per height. And so just kind of put it into sort of physiologic perspective, and then you start to understand the challenges that our patients and maybe even us put on our heart because of sleep apnea and hypertension and obesity and valve disease and diabetes. Don't let anybody tell you anything different. So we can get back to diabetes and vascular disease in a minute. All right, so now we've got just a basic understanding of this. Now what's happening at the cellular level? Oh yeah, chalk. So what's happening at the cellular level to make this happen? Does anybody remember these curves? Guyton physiology, anything? No textbooks? Doesn't ring a bell? Guess that was what I beat myself up with. Anyway, so this is the SA nodal depolarization, repolarization with ventricular depolarization, repolarization. And the reason to remember this is because we, as the medicine docs, our scalpels are our medicines. And so we have to understand what medicines am I given, why, and when do they work, and what's the effect. So every single thing on here is something that we manipulate somehow with our medical therapies. People don't quite think about it that way at that level, but it's important to kind of let your brain dive down into the molecular level of what we're doing, because that's the precision of the therapy. So if you're thinking about intracellular mechanisms and sodium and potassium movement, now you're thinking about how to really treat people. So this is sodium into the cell, calcium and potassium start moving, and then potassium back out. So there's all this movement. And so when people talk about calcium channel blockers and beta blockers, what they're really talking about is trying to manipulate aspects of this curve and certain timings of it. When we use antiarrhythmics, we're manipulating sometimes the sodium channel action, sometimes the potassium channel action to get changes of how the heart is going to depolarize, repolarize, and create, or let me say, reduce excitability a lot of the time is what we're trying to do. So especially in AFib and all these arrhythmias, we're trying to say, ooh, man, slow this thing down. Don't be so excitable. So just to remind you that all this stuff is happening in the background in my brain while I'm giving you med recs. So I want it happening in your brain too, because you're going to help me think through this as we take care of folks. All right, so let's talk about basic changes of the conduction system. So let's go through blocks. That's pretty straightforward stuff and very important to be precise in your understanding of what is a block. So what's the kind of, let's go hierarchically, top to bottom. So what's the first level of block that I told you most everybody blows off? First degree. All right, so how do we define first degree AV block? PR interval greater than what? So 200 milliseconds. That's the other thing on the EKG. Let's just review very quickly. So these are 40 milliseconds each, so 200 milliseconds per big block. And then you got to start letting 60,000 be a number you divide things into. Because 60,000 is how many milliseconds are in a minute, and so now you can divide these intervals into 60,000 and figure out how many seconds per minute, etc. So that's just basic EKG cardiac stuff. All right, so first degree AV block. Now we already talked about this being these three signals. So the point is that from the hiss to the V is typically less than 55 milliseconds. And that is a fixed interval, meaning it's not going to change. You know, big black bear shows up, bad guy, something's on fire. HV is still going to be the same. AV may shorten, or pardon me, may shorten because of the properties of the AV node, which are happening in here with the atrium. But the point is the HV is fixed. So when people blow off the first degree AV block, it's most of the time because the HV is fixed and not abnormal. And it only accounts for 55 out of this 200 milliseconds. So really only 1/4 of it. But the point is that sometimes we do find problems in there. Okay? And I'll show you with some other blocks how to figure out where that problem really is besides putting a catheter in there and measuring it. Okay? So then what's the next block? Second degree type 1. So what is second degree type 1 also called? AV Winky Bach. Okay? Now, explain that one. What is second degree type 1? You're looking at an EKG. Yes. Now, I'm going to help you finish that. That was a good definition. I'm going to help you finish it on the way that you look at the EKG and then make sure that you're sure. So the PR prolongs progressively. Sometimes not even progressive. It just gets long, stays long, and then it drops. What's the PR of the return beat? Back to normal. So it'll be shorter. So you have, let's say, a long one. You have a P, nothing. And the point is that PR on the return will be shorter than the last conducted PR. So that's just a little extra to look at the EKG with that's different than what you were taught as, just the pattern before drop. But now look at the next beat, and that'll absolutely confirm second degree type 1. Now that's important because the question is where does this second degree type 1 typically happen? Is within the AV node, okay? Almost never progresses to heart block. Almost never. So in population studies and watching patients who had this, like back in the 60s and 70s when we were first starting to really watch people and have monitors and do things, what we figured out is within 3 to 5 years, a pretty low percentage of these people progress to heart block. So the problem is usually in the AV node. Now, why is AV Winky Bach a good thing to have? Why is that helpful? It's protective, actually. I hope that I winky balked when I was asleep last night with my high vagal tone while I wasn't apneic. Well, more specifically, I'm pushing you a little bit. I know what I am asking, but you may not. The point is, think about atrial arrhythmias. So now you're in AFib, and the top chambers are quivering, 300 to 600 beats per minute. Okay, total chaos. Fibrillation. Just let's sort of step away from these terms and understand what each word in each of them means. Fibrillation, either atrial or ventricular. Just understand electrical chaos. Okay, electrical chaos. So in the atrial situation, you're not going to die if the atrium's doing that, but if the ventricle is, it's quivering and it never fills, so it can't pump. So that's why VFib and VTAC will kill you, is because now the real big ventricular pumping chamber is quivering to a point where it doesn't function. So it's all timing, So that's why I keep kind of going back on these intervals and understanding timing. Is it's really the impact on the hemodynamics that the electrical system has. All right, so atrial fibrillation. Now we're sitting there quivering, top chambers. I'm getting ready to go take care of 2 flutters later today. We'll get into flutter versus fib, don't worry. So now you're 300 to 600 beats per minute. What if that AV node didn't winky bach? And it said, whatever you want, champ, come on down, 300 beats a minute. The ventricle will fibrillate. And so the point is the AV node saves every single AFib flutter patient that you have from dying. So that's why this is very important. So this is a protective mechanism as much as perhaps a reflection of pathology. So just understanding, I test in the EP lab when I'm going through these SVT studies, I find everyone's winky buck cycling. I pace them down to a point, and everybody's going to winky buck at some point. And so that's just something we're observing that is normal. But again, it can be abnormal if it's happening while you're at rest and not in some sort of stress mode.
So you're saying like because it resets, it never gets to the ventricle?
Because it has an upper limit of conduction, it doesn't allow all the fibrillatory signals, or if I sat up there and paced at 300 beats a minute, it wouldn't be able to conduct down to the ventricle because somewhere along the way, nature sorted out that ain't a good idea. And that's where we can get into Wolff-Parkinson-White syndrome with accessory pathways, but we'll get to that later, okay? So that's second degree type 1. So now, what's the next one? You can't answer all the questions. You've already been to the lecture, man. Yeah, I'm picking on you. All right, what's the next block? Type 2. All right, so how do we define this one? Say it again. Without any warning. Okay, so a different way to say it is there's no change in the PR interval before the drop or after the drop. So it's a fixed PR, then an A drops, and then the PR returns. And so the same thing, like I said, the real way to determine it is you measure the PR before the last drop, before the last beat, and after. And it should be the same. Okay, so that's really, as much as the pattern preceding the drop is the way to determine it, it's the beat after, the return beat, that will nail the diagnosis to say, that PR is exactly the same. That's second degree type 2. Now, why, again, what is different about second degree type 2? Where does this block occur? We said second degree type 1's in the AV node. Remember, we're still in the AV block. We're still dealing with PR. So what occurs within that PR interval? Not yet. We haven't gotten to the ventricle yet. We're still in the PR interval. We're still talking about it's in the His bundle. Now that's not good. Because as soon as I see this happen once, and it occurs within the His bundle, observational studies showed us 50 years ago, these folks progress to heart block, complete heart block, much faster and with much higher frequency than do the second degree type 1. Because the bundle of His is a go, no-go. Everything before it within the AV node is decrements. You go faster, nope, I'm not conducting anymore. But the His is fixed. It's 55, but when I speed it up, it goes 65. HV interval is a fixed interval. So like I say, it's a go, no-go circuit. So if you ever see it not work once, second degree type 2, it's going to fail. And that's an indication for a pacemaker. You ever see second degree type 2 one time, you should give that patient a pacemaker. And so there's no perseveration about it. Now, if you're symptomatic with second degree type 1, which is kind of tough to figure out because there's usually other stuff going on, the indication, I think, is like a 2B to give a pacemaker. But second degree type 2, that's a pacemaker. And then the last one, third degree. All right, and so what is the definition if you're just calling your mama? Mom, this guy's in third degree AV block. I got to tell you what that means. What's happening? Everything, I like that. That is how you would tell your mom. And she would say, I got you, man. So it's AV dissociation is the formal terms. And so that's, nothing talking from top to bottom, and again, pacemaker at that point. All right. So let's talk about basics of pacing and devices. And so we'll kind of get into some stuff about devices, because I know y'all take care of a lot of folks who have a lot of stuff. And I love getting consults from certain departments where the telemetry has indicated that the pacemaker's not working. That just means they're not reading the EKG. So So remember, a pacemaker now is designed, just a pacemaker, is designed as a safety net. So you'll get the question, was this supposed to help my heart from going too fast? The answer is, That's for all the medicines, that's for me to do ablations, that's other stuff. The pacemaker is to keep you from going too slow and to synchronize AV, top, bottom, so that there's no big delays and that it again, maintains the hemodynamics, the synchrony. So, standard pacemaker, about the size of a silver dollar. Usually, we've got one lead in the top and one in the bottom. So, dual chamber pacemaker. Sometimes you'll see a single chamber. If we had all been practicing back in the 90s when EP ablation and studies weren't where they are now, people used to get single chamber devices up in the top chamber to pace them out of, and that was one of the few times the pacemaker actually broke it, but to pace them out of SVTs. And we'll get into that when we get into mechanisms of SVTs. But you'll almost never see just a single chamber atrial device. If it's a single chamber device, it'd be one lead in the ventricle. And remember, the idea is just to keep you from going too slow. All right, so then when you see all those letters, I'm going to kind of just stick my toe in this real quick so that it's not Greek and gibberish to you. There's usually 4 positions to just, that's a terribly unstraight line. But this is what they stand for. So you've seen DDDR, you've seen VVI, all these different abbreviations. So the first position in all of these abbreviations is for what it's going to do. What can it pace? All right? And the way that I remember this when I was in fellowship was, psst, hey, psst, come over here, psst. So that you can remember your acronym. Pace, sense, track. So the first letter demarcates what chamber it can pace. Either the atrium, the ventricle, or both, dual, D, okay? The second is what it's going to sense. So what is it going to listen to tell it when to pace? Because what I can do sometimes is I can put it in a VOO, meaning I'll just pace the ventricle. I don't care what the ventricle's doing. I don't care what the atrium's doing. Just hammer it. Pace away. So like a temporary pacemaker, we typically do like a VVI 40, 50, 60. And that's from a critical care standpoint. You'll get somebody from the cath lab who's got a temporary pacemaker maybe down in the ER. And so you set that device down to like VVI 60, VVI 70, you know. Again, I don't want to get too deep into this because that's a whole other conversation about how to set pacemakers and how to coordinate them. And I don't think we need to get into that. But to make you familiar, each of these positions means something, okay? And you can kind of dive into that a little bit. We've started putting all of our device interrogation stuff in cards procedures tab now. We used to hide it over in media. You'd have to go dig it out. We've got a new program that now downloads these reports. And so it's findable stuff and it's important for us. All right, so that's a single chamber pacemaker. So then, what is a defibrillator? And you can tell the difference on EKG, on a chest X-ray when you know what you're looking for. So the pacemakers tend to be about the size of a silver dollar and about that thickness. And defibrillators are more like the Boy Scout salute, more like 3 fingers wide and about that big. So they're a box. Now, why is that box so big? And what does a defibrillator do that's different than a pacemaker? Shocks them. How does it shock them, though? And this is where it's just a little bit of extra knowledge. You're going to see through some stuff that you just never knew to even look at. Probably about 2/3 of this son of a gun of that box, and why it's bigger, is something called a capacitor. What happens is that when it's time to shock, this little device can load up its energy out of its battery and stack it up into this capacitor and hold it at high charge and then deliver it suddenly. And so that capacitor is the critical component of this defibrillator, despite having a little bit more stuff going on in the chip, in the computer, to differentiate some stuff and make some decisions. It's all algorithmic. It's all stuff we control and can program. But that's just to know basic stuff of why these devices are different. So it has a capacitor. The idea is that it can deliver that energy here that will give a vector, and we can change these vectors of how it shocks from the can to the coil, coil to the can. If you have a second coil, you can create vectors of shock. And the idea is that this left ventricle is either fibrillating or in ventricular tachycardia, and that shock will save it out of that. Okay, so the defibrillator, what are the indications to have a defibrillator? Talked about pacemaker, okay? So, second degree type 2 or AV block. Symptomatic bradycardia would be another one, but anyway, so those are kind of your basic pacemaker indications. So now who gets a defibrillator? Hopefully not me ever. I love it when patients see it on the posters in my office. They're like, am I getting one of those defibrillators? I'm like, you don't want one, man. Absolutely. So we call that secondary prevention. Okay? If you have an observed VT-VF arrest, secondary prevention, you get a defibrillator. You'll see, I'm giving you the words that I try to document in regards to substantiating our clinical decisions, because you'll see this stuff come up over and over and over. So yes, if you have observed VF-VT, you get for secondary prevention.
Is there a way to, like, I know you probably remember this case, but that 19-year-old that was cut in glass passed out. So can you tell that he was in it, like he never had an episode?
So it's funny you mention that, because that was what I was just thinking to make a reference to. I was like, that's a little obscure. They're not going to quite get that. But how did I put that together? So the coach was the most critical interview that I had to figure out what was happening. And I let him tell me the story. Did you all hear about this case? A 19-year-old kid, big-time athlete all through high school. He's at his baseball coach's house helping to work on the diamond at his coach's house where he goes every day and works out. I mean, great kid. And coach says he's just riding around on his mower, and he looks over and he can't see him anymore. And he goes up and he's collapsed on the ground. And he said he tried to feel a pulse, couldn't feel a pulse. He starts CPR, and the kid was out and pulseless. So he continues CPR, finally gets EMS there. EMS gets there, they start CPR, but it wasn't until they shocked him that they got a rhythm. So that was all the evidence I had to be able to make that decision on him. But in the end, we actually did genetic testing on him, and he has a mutation. The way to tell was, look, and I might have perseverated about that a lot more 10 years ago. So I can't tell you. I mean, it's just about, you got to hear the story. And if my job is literally to shut up and listen. And when these people tell you what has happened to them and how things went, very often you can deduce what happened without seeing a tracing. But I think in his case, because it required a shock to restore pulse, that was kind of the clincher to say we should protect this kid from a ventricular arrest.
So when you say you did genetic testing, did you show family history of?
No, so of course he's adopted.
Right, from Russia.
Super cool. We like that. It's crazy how these channelopathy guys, and we'll get into the channelopathies and stuff in the second half of this. But in these guys who have these mutations with the channels and they mishandle sodium very often is one of the main things, sometimes potassium, they will have, what we do is we send it off ARUP, and I forget all of the genes, but they're tested for long QT, Brugada, and a number of things that y'all hear about maybe once or twice, but not a whole bunch. And they identified a gene mutation of no known clinical significance. Well, we've had 4 patients in 10 years that have had mutations of no known clinical significance, but then you go look at it and you do the Punnett square, and they've had these people and whatever. You start identifying Uncle Addie and Aunt Nettie and whomever, they died suddenly at 32, and he collapsed at 34 in his yard. And you start putting together all this stuff. Every single one of these people, besides this one kid who's adopted and can't tell me, have had other first-degree relatives who have had genetic testing with the same mutation, but because I haven't taken the time to publish it, or whoever else figured it out, didn't put it in the literature, then the reporting agency can't say we have literature to support that this is clinically significant, but then you've got to treat the patient. And so in this case, he got a sub-Q ICD, which is a pretty cool device. I don't do a whole bunch of them, but in young kids like him, it's a pretty perfect thing. The defibrillator box goes in the posterior left axilla, and then I run subcutaneously a wire, a coil like this, under the skin. And that wraps the heart like you would pads. to shock, and it's all under the skin outside of the heart. That's so that he got the sub-Q ICD because he's going to go off and play sports.
He's so young and you may take it off?
He's so young. No, I probably won't take it off, but he's so young and he may grow. And it took me one case of trying to extract a defibrillator lead from a 12-year-old who had had it implanted when he was 6 because he had arrest and he was long QT, and then he grew and it pulled the lead back. And so we told the mom, we're not so sure we should take this out. We should just put more leads in there. She said, but he's got to do this for the rest of his life. And we had a traumatic extraction incident. Kid expired. So point is, these things, this is all, people think, oh, just put when people say just put a defibrillator or just do this or just do that, I have gray hair in my beard from doing just all these things all the time, okay? Because the point is bad shit can happen when you start poking on people. And you got to understand when you're going in, it's the way I talk about it is Sun Tzu and Art of War. Have planned egress when you ingress. When you attack, have a retreat. So the whole thing is when you're putting these things in, you better know how to handle them. Because it's not just when they're working right and everything's sunny. Fine, every yuck can do that. But can you handle it when shit goes wrong or when there's problems here and troubleshoot it appropriately? That's where the real level of understanding comes. So defibrillator, like I said, the reason to point out about the lead is you'll see him on chest x-ray, and then you'll be able to tell me, hey man, that's a defibrillator, not a pacemaker, over the phone. And those coils are what handles the high energy delivery. Okay, different than a regular pacemaker lead. And I wish I had some examples to show you, but catch me on the floor, we'll pull up some chest x-rays and I can show you some stuff. So that's an important delineator, but also to the size of the box. Okay, so without even knowing the guy, doing an interrogation, anything. And from the ER side, I get it all the time. I'm not sure what device he has. Well, look at the chest x-ray, man. Tell me what he's got, So there's some things to think about. Now, so that's standard dual chamber pacemaker and defibrillator. So then we're going to get into biventricular pacing, but I think we ought to talk a little bit more about cardiomyopathies and these, because then we can kind of finish the pacing talk and then we'll get into some other arrhythmia stuff in a second. So it's important with kind of setting the stage for understanding the electrical flow to then talk about cardiomyopathies. And so what are the two main kind of branches if you're looking at it down organization tree on a page? If you had to draw it out, all right, Mom, here it is. This is what cardiomyopathies look like. How would you describe the two main groups of cardiomyopathy? There's this versus that. Dilated is sort of down in the tree later, but the main two delineators. Ischemic versus non-ischemic. All right? And so ischemic is you've had multiple heart attacks. The heart attacks have created scar within the tissue, and now you have dysfunction because of the scar. Okay? So that's all of our coronary disease patients with bad hearts, bad function. So ischemic. Non-ischemic is more of viral cardiomyopathies, which happened, by the way, well before COVID. Okay, well, I've taken care of viral cardiomyopathies my entire career because people get them from Norwalk viruses, rhinoviruses, God knows. Some studies had shown Coxsackie to be a big one. There were not great studies and we didn't have good virology. That was like 35 years ago. So I would love to see what some virology now showed in regards to what are true non-ischemic etiologies. We estimate about 50 to 60% of them are viral cardiomyopathies. Then you have another 30 or 40% that can either be infiltrative, idiopathic, we say, which means, I don't know why, it just didn't work, sorry. And so the infiltrative stuff, you start getting into sarcoid and other lupus and some other bad things. Amyloid's a big one, bad, kind of under-recognized until just probably the last 10, 15 years. And so amyloidosis is a big, big deal as it pertains to non-ischemics because they're tough to treat. And it's usually a very bad prognosis. So then, in heart failure, what are some of the medicines that you see us use? Okay, so we're in the unit, you're using inotropes, we're using IV diuretics, what else? Okay, so what are some of those? Because you keep
I mean,
talking.
it's not that bad, it's not the opposite of whatever we use to lower the blood pressure. Cardiac, nitrite.
Okay, so you're treating hypertensive emergency at this point, but anyway, point is not heart failure, but I'm with you. Let's afterload reduce. We can get into all that. What else? So yeah, now you're barking up my tree now. I like that. Pander to the lecturer. You got to keep them in normal rhythm and stuff. No, some of that is very important. We'll get to the data on maintaining normal rhythm. Yeah, you're damn right. All these pills we push, right? Remember I told you, the pills are our scalpels in medicine. And we need to know exactly how they're working, or I can't cut that tumor out. I can't get that knife around that surgical spot. So the point is that you've got to understand the precision of these drugs. So Entresto is a big new one. What are the parts of Entresto? Sacubitril is the other, the new part. And sacubitril keeps the body from breaking down brain natriuretic peptide, which is your natural diuretic that your heart tells the brain to make when it's stretched. So that's really cool. So let's think about, you know what, I'm going to draw this in a different way. So okay, so right atrium, right ventricle, left atrium, left ventricle. So it's important when you're talking about heart failure to hear this term and then think about it over and over and over and over and over. Neurohormonal axis. Neurohormonal axis. What we're treating when we treat heart failure is we're blocking the neurohormonal axis. It sounds a little provocative, a little dirty, but it's not. So it's how the brain and the vagus nerve handle all of the receptor information that it's getting from the heart when it's failing. So think about it. When the ventricle's not pumping well, let's just go to a cardiomyopathy where the EF is down. You have to understand that the body is regulating itself kind of like your vehicle does in regards to all these little checks and pressure measurements and alarms and alerts. It's a computer. It's the original nature's computer of carotid stretch, aortic stretch. You know, the kidneys are seeing certain amounts of flow or lack thereof, and they're having responses. And so the point is that all of this is mediated by the vagus nerve. And it's all of these receptors that are telling the heart or telling the brain it's not working. So when you don't have good carotid stretch and you need more blood, and the kidneys say in their nephrons, which I love more than some nephrologists do. That was a shot. What is that? Why does a cardiologist draw on a kidney thing? Because I love it. What did I just draw for you guys? Juxtaglomerular apparatus, I think I heard. That's it right there. Okay. And then the nephron. Okay. So this, when you talk about, I'm going to mess with the kidneys. I'm not poking on a bean. We're poking on anatomical nephrons. Like the kidneys are just filled with these things. That's the functional unit. And so you got to know what's happening in each of these things because our drugs do stuff to them. So if I don't know how they work, why should I poke at them with medicine? So the point of saying all this is the basic drugs for goal-directed medical therapy. Beta blocker. Afterload reduction. I'll just put that in there. I mean, those two things are probably the way to give the big summary descriptor of the medicines. And so when you go down the list, you're talking about Toprol, Coreg. Those are the two biggest ones that have been studied and have proven to be the most efficacious. So that's why you see us use a lot of Toprol, Coreg, not just because they brought us dinner last week, haven't in 20 years, by the way. But the point is because those were the drugs that were studied to show the most efficacy. Now, why does Coreg get us excited? Because it's not just a beta blocker, it's a alpha blocker. So it reduces afterload by alpha blockade and gives vasodilation. So Coreg not only blocks the adrenaline effect, because when the carotids aren't stretched, adrenaline is the release. Okay? And adrenaline, as cool as it is, make you jump over the fence or grab your kid out in front of the Mardi Gras float, it in high doses with chronic stimulation results in apoptosis and scar in the heart. And so when we see these people who have cardiomyopathies, when we intervene early with these medicines, we block the body's effect of the adrenaline. Why does that make sense? Because think about it. Let's go back 10,000 years, okay? I don't know if we're wearing loincloths or robes or what we're doing. But the point is now I got a sick heart. I don't have any understanding of all this stuff. And I'm hungry, and my kids are hungry, and there's a saber tooth. I'm going to get up and fight. I might, not as well, but the point is adrenaline's going to help me do that because adrenaline helps you overcome limitations, okay? So just kind of dumb it way down and think about it from I'm trying to survive. So the sick heart gets pulsed with chronic adrenaline. It's whipping the horse. It never lets the horse rest. So what we're trying to do with our drugs is block the effects of adrenaline, neurohormonal axis. So you're blocking your adrenergic nervous system and its effects to try to drive a sick heart and keep you alive. Because now you don't have to go hunt for food. You don't have to walk a mile to get water. You don't have to run up the tree because the bear's chasing your ass. You live in Covington. So the point is you get to go into 70 degrees interior and go to the grocery store and do this stuff. So living is easier. So now instead of driving the adrenaline, we can block it. So we get beta blockers. That's, like I said, Coreg and Toprol. But now, the cool part is it's afterload reduction. And this is where all the new drugs are really, really neat. Because you have, since the late 90s, early 2000s, you have ACE inhibitors were the first class, so lisinopril, captopril, enalapril, those drugs. And why is that important is because renin-angiotensin is part of the adrenaline axis, and its afferent flow and efferent flow within the juxtaglomerular apparatus affects how the nephron works. So the point is if I block ACE, then I reduce vasoconstriction and I get better flow to the kidneys. So now the kidneys are happy because they're getting better flow. And because what is the renin-angiotensin system designed to do is when you're dehydrated, tell you to hold on to fluid. So when patients show up in heart failure, they're all held on to fluid because their kidneys are confused. They're not getting perfused properly, and all these receptors have confused them to say, you got to hold on to this stuff because you're dry. Okay, so you understand the kidneys are integral in cardiovascular therapy. All right, so ACE inhibitors, ARB, same thing. Now, we talked about sacubitril with valsartan. So long-standing ARB that we've used, we've shown it to be a very good drug in heart failure. It's studied very well. But sacubitril, like I said, keeps the body from breaking down this brain natriuretic peptide. So when there's stretch on the ventricle, the body is signaled to release this BNP, but then the body also breaks it down very quickly. It's just kind of one of those things. It's a little balance of the biochemical signaling within the blood. So sacubitril now blocks that breakdown, and it increases solute in the tubule and increases output. Okay, so Entresto was a major boon, a very, very big, important drug for us to have because we hadn't had a new heart failure drug in literally 20 years since Coreg. So, big deal. Entresto changed things. It was great. Well, right on the heels of Entresto comes some folks trying to treat diabetes better. And they release Jardiance. Okay, so how does Jardiance work? Crickets. All right. It's an SGL2 inhibitor. And the point is that it keeps the body from pulling glucose out of the urine. And so what does that do now? It keeps more glucose in the tubule, creating solute and then increasing output. So those knuckleheads trying to treat diabetes, which is incredible, stumbled on a novel diuretic. It's really, really cool. Farxiga was, like I said, initially just about diabetes. And in all their retrospective data, they were like, why are our heart failure patients reducing hospitalization? We had reduced mortality. And then Farxiga comes out, also an SGL2 inhibitor. And Farxiga said, wait, all these nerdy docs keep saying, I ain't just going to do it because you said so. I need a study to prove it. And Farxiga did all the trials where they went head-to-head with Farxiga versus placebo in patients with heart failure, studying specifically in heart failure, not diabetes. And so what they found was all these improved outcomes with Farxiga compared to not using it. And so then why do these diuretics and why does all this proximal tubule, increased solute all help? Is because of this reduction of afterload. You open the kidneys up, you get more fluid off, you get less stretch, you get less of the adrenergic tone on the body. And the heart now doesn't have to work as hard to pump into a lower pressure system because you're reducing the afterload. You're reducing preload and afterload. But the point is it improves hemodynamics. So now, if you wanted to script the perfect medical regimen for someone with a cardiomyopathy, ischemic versus not, whatever the point is the goal-directed medical therapy would include corregortoprol beta blockade with some alpha, if you can afford it, from a pressure standpoint, because we take care of a lot of folks hover in the low hundreds, whatever, and you're trying to give them all these medicines and you're dropping them and stuff. So the point is, give me some blood pressure and then I can treat you with all these meds. But you want beta blockade with hopefully afterload. You want ACE or ARB, so in your sacubitril, you'll get your ARB with sacubitril, and then the SGL2 inhibitors. And that kind of, again, is blocking adrenaline in a number of different ways from affecting the physiology of all these parts that are affected from the bad pump. So that's the pharmacologic therapy, it's kind of the approach to cardiomyopathies. Now, trying to think from a cardiomyopathy standpoint. Let's talk about, I'll go back to devices real quick. That's what I was going to tie it into. All right, so the last bit of how to tie cardiomyopathies into devices is with a biventricular device. So what would be the indications to give an extra lead, not just regular pacing or defibrillating? And this is cool because this is when device therapy helps people, okay? So you'll see, like I said, the majority of folks sitting there with a cardiomyopathy will have their dual chamber defibrillator. Let's just leave it there. But then why would I want to add a left ventricular lead? The number one indication is a left bundle branch block with a wide QRS. Now, let's make sense of that. So if I have a left bundle branch block, immediately in your brains, y'all should have an EKG picture that pops up in your head. And it should look something like this. And so the point is that if these bundles don't work, the electrical flow initially goes to the right and then slowly gets over to the left. And that slow, quote, depolarization is literally milliseconds difference. But when we're talking about making this bag of steaks beat, milliseconds will make it a little wobbly instead of synchronous. And so what you really want, like I said before, is with those two bundles going all the way out to the edges, you want out to in. You want synchrony like a bellows. At a blacksmith shop or at your fireplace. You want it to go like that, together, both ventricles. And in doing so, it lets the septum, the interventricular septum, remain stable and stiff. And it treats it like a backboard because the outflow tracts are coming right here. So the point is squeezing out to in, stiff backboard, blood goes out. Blood goes out every beat. With a left bundle, though, you get right, left, right, left. And so that even just that mild perturbation within milliseconds of depolarization of the ventricles equals a less efficient pump. And so then what I can do is go through the coronary sinus, which is the venous drainage that's riding on the outside of the heart, and I can, from the right side, place a lead through the coronary sinus and out here to the left ventricle. And so now what I've done is kind of created a surrogate for that left bundle that's no longer working. And I'm getting an electrical signal out there, and I'm going to time it with the right ventricle to maximize output and recreate synchrony. So when we say you have a biventricular device, the goal is therapy. This isn't just save you from the fast stuff, but it's to make you feel better and function better.
So when you do that, do you have to block that with the
No. They
Or does that fight against what you're doing with the?
No, they typically have the left bundle. You don't do that until they manifest on EKG and you say, oh shit, look, you got a left bundle. And what I'll have is I'll have a handful of non-ischemics that I've had over time, not a handful, more than that. They start with narrow QRSs, but as their hearts get sicker and dilate and more scar develops and they just are decompensating, they'll develop that left bundle over time.
I guess my point, like if you put the other lead in, what stops the normal pathway from fighting against?
You shouldn't do it if the normal pathway is
So
conducting.
It's just non-existent.
It's not indicated. If you don't have a left bundle, and you kind of go through the guidelines to say, what did the study show? Is left bundle, QRS greater than 150 with symptoms. Those are the ones, that's the class 1 indication, put in the left ventricular lead, you're probably going to help them. By the studies, we found out non-ischemic females with a left bundle greater than 150 are the biggest responders. And I've had some great cases where we've added a left ventricular lead or put in a BiV device, and all of a sudden their EF 3 months later is back to normal. I mean, that's when you walk out, kind of feeling it, because you just...
So in that case would be like congestive heart failure because the left ventricle's not inferior enough and it's back down to the lungs and all that?
So it's not, I guess the way to say it better is to say cardiomyopathy of any flavor with this lack of flow, synchrony, based off of the left bundle, deserves a shot at resynchronization therapy. And that's the addition of the left ventricular lead with the attempt to resynchronize. And we do. I mean, it's really neat when you can recover an EF from 15 to 20 up to even 40, 50, 60. I mean, that's big stuff. You've just changed someone's life. It's really, really neat. And so they're not just from a cardiomyopathy because your heart got sick separate. Pacemakers can make people have cardiomyopathies. I've had a handful of folks, we put in just a dual chamber pacemaker, but they end up pacing 100% of the time, and that just pacing from the right acts like a left bundle. And so now they drop their ejection fraction because the pacemaker's just pacing from the right, and it's like it's created a left bundle, and it creates that dysynchrony. So then what we have to do is if you drop your ejection fraction because I'm pacing you too much, I add a left ventricular lead. Now we're pacing you 100% of the time from both sides, and typically we recover the function. So, that's the crazy part about our job is there's a lot of stuff that we do to try to help people, and then it can hurt them. So you're always trying to be very judicious in picking what you're going to do for someone because you know what you're doing trying to help them can hurt them. But that's why I said the real level of expert then is not just know what to do the first time, but when shit goes wrong, okay, now let's pick up the pieces and fix that. You got to fix the fix. Got to troubleshoot your intervention. And that's when the complexity of what we do starts to stack up a little bit. So that's pacing, that's cardiomyopathies and pacing indications. That's BiV pacing. From a procedural standpoint, they're really cool, but it's always like I'm walking outside right before the case kind of trying to get myself ready because it's a battle to do these BiVs sometimes. There is so much technical stuff going on to get these wires way out there and balance them, and they'll flop out, right? You're in the middle of stuff trying to get it done quickly for this poor guy or whatever. And so it's always like, you're walking on the field, getting ready to play a game when you're doing these things because you got to get kind of pumped up and ready to rock because it's not just going to go. You're not just doing walkthroughs in practice. I mean, this anatomy is complicated, the techniques are complicated, you're using a lot of tools. So always a challenge. I respect the BIVs. All right. So questions so far. We've covered kind of basic conduction, basic blocks, basic pacemaker, defibrillator, BIV, cardiomyopathy. We've covered a lot of territory. It's kind of skimming the surface on a lot of stuff, but I think it's good to hear it from an intro and try to tie it together from an electrical side. So any questions so far? Yes, sir.
Can you explain how a pacemaker is like an insulin pacemaker is infected? Like another area for
Gets infected?
yeah, like infected.
Yeah. So your blood space should be sterile. How do we introduce bacteria into the blood space? Any possible way you can imagine. So dental procedures, that's one. Bad rotten teeth. My favorite bad rotten tooth story is the lady who showed up cocaine positive with chest pain, and she said she was using cocaine to treat the pain on her tooth. It was a novel excuse. Respected the creativity. But IV drugs and IV drugs from us. Indwelling lines, HD accesses, ports, any way that bacteria can get into the blood is how it can become infected. If you think about bacteremia and then what side and introduction do you think the heart's going to get sick first, you can perseverate on that or just figure it out for the patient individually. But most of the time, if it's IV driven given, from a port or a needle or whatever, it's going to be on the right side, on the tricuspid valve. But if it's systemic enough and you're floating around with enough bacteria, it can certainly get on the left. But yeah, it's inoculum of bacteria. Dr. Kubel, who unfortunately a lot of you didn't get to meet before he retired, was a very witty gentleman. And one of my favorite clinical summaries in an assessment and plan he did was of a gentleman who had presented now multiple times with bacteremia because he liked to crush pain pills and then inject them. And he had a bioprosthetic valve from endocarditis about 2 years before. And he presented with bacteremia from doing the same thing. And Dr. Kubel's summary statement was, an unfortunate gentleman who has attempted to kill himself repeatedly but is as of yet unsuccessful. I thought that was fantastic. So, that's to answer your question. Yeah, and then what do you do with endocarditis? Man, that's a whole nother, do you replace the valve and do what are the indications for different things? It's very tailored, but if there's valvular destruction and dysfunction from the endocarditis is when we say, okay, maybe surgery is going to be the way. But very often what we try to do is sterilize the endocarditis with antibiotics and the magic salts that the ID guys sprinkle around all the time, and then try to keep that from growing too bad and tearing up the valve too bad. Any other questions right now? All right, who's ready for SVT? Cool. I'll do SVT, and then we'll talk about ablation of SVT and AFib, flutter, and some other stuff so that you know what I'm doing in that dark room down the hall over there. Okay, so SVT, another kind of umbrella term to describe three main processes. And so the nice part about organizing these terms and understanding what you're actually referring to will help you clinically approach these patients more precisely. So SVT, three things: AV-NRT, AV-RT, and atrial tach. I'll talk about each one of those and explain it. But that's it, okay? Now, you can talk about sinus tach, paroxysmal junctional tach, some other stuff, but we're going to stay focused on the three big ones. So, right side left, atrial ventricles, sinus node, AV node. Now I'm going to take this side of the heart and turn it sideways. So this is like you're in the lab with me, and we've got an RAO camera view looking at the heart sideways. This is the AV node. Sinus node's kind of living out here in space. All right? 75% of people have one input into the AV node where the signal from the SA node gets into it. That means 25% of people have a second input. That's a whole bunch of people. Something like 2 billion human animals walking around with this extra thing. Okay? So, these two pathways have different conduction properties, which is what sets them up to create the problem. And so this is called the fast pathway, this is called the slow pathway. And the point is that with a sequence of extra beats, usually PACs, you'll catch one of these not ready, it'll conduct up this slow, and in the time that it conducted up the slow, now this is ready, it conducts back and whips around. And so it creates a little micro reentrant circuit. This one's called AV NRT, and it accounts for about 60% of these guys. So this is the one that presents, that y'all see in the emergency department, with a very narrow QRS, and then right in the terminal portion, you have a little P wave sitting, just hiding in there. And it's because what's happening is that you're depolarizing the ventricle at the same time as you are the atrium. So you're going both directions out of the AV node, back up to the atrium and down to the ventricle. So you get the depolarization of the ventricle with a retrograde P wave. And I can see that on, if you specifically look at V1 and lead 2, we'll talk about leads here in a second. You look at V1 and lead 2, that's when you can see the little P waves, and they should be opposite each other. Now, why does that make sense? Let's go into the vectors now, just very, very quickly. So you have to think about EKGs as camera angles. Okay, so lead 1 is sitting out there, and there's a camera angle, it's watching. And so it's going to get positive if the electricity flows toward it, and it'll be negative if the electricity flows away from it. 2 is sitting down here, V1 sits here. So the reason that I say, with the heart sitting like this in your chest, V1 and 2 is what I look at to tell you about P waves, is because they're 180 opposite of each other, and they're looking from the top and the bottom of the atrium. Okay, so that's just a forever, for the rest of your life. If you were wondering, is this sinus, is it flutter, is it whatever, look in V1 and 2. Promise you. And then we'll be able to have a better conversation about what's really going on there. Okay, so lead V1 and lead 2. And we can see the changes in the P waves and the QRS when you're in AV NRT. Okay, so this is one of the ones you give adenosine for, and it breaks like that. How does adenosine work? Remember, that's your scalpel. If you don't know how it works, don't use it. It does. How's that? That's like saying a mechanic works on a car. I'm picking on you. It does block it somehow. That is correct. Anybody have an idea? Anything else beyond that? So it's really a pretty unique drug because it actually hyperpolarizes the AV node, and so specifically in potassium channels. And so what it does is it puts it in a state of activation, but doesn't let it repolarize. So it depolarizes the AV, so it blocks it by activating and not letting it reactivate. So kind of a hip thing. And so the reason to understand it is that if the circuit involves the AV node and now you block it, the circuit can't perpetuate. So the concept is about knowing what's in the circuit and what does this drug do to that circuit. So it hyperpolarizes potassium, keeps it from deactivating so it can't reactivate, and so it blocks it. Okay? So that's AV NRT. Now, when you're forming in your mama's belly, and there ain't no valves yet, and now the valves are starting to form, as they do, they start to fibrose around. Just imagine the simple concept that if there's a little pinch of muscle that valve ring doesn't entirely encapsulate and cover over, that muscle can act like a wire. And that's called an accessory pathway, a bundle of Kent. You've heard all these terms, just like maybe didn't know exactly what they were. I draw it here in the sort of left posterolateral aspect because this is where the majority of them come, but I've found them up right here by the AV node, right out here. They happen all over the place. And with these accessory pathways, there is the concept of pre-excitation to talk about. So people can have accessory pathways without pre-excitation, but the pre-excitation gets the ER docs excited. It's pretty fun. And they're like, oh my God, we have delta waves. What are we doing? It's Wolff-Parkinson-White syndrome. The guy's going to die. Like, whoa, slow down. Now, remember I told you I'd come back to that, so let's talk about that. So the point is that a delta wave that indicates pre-excitation is because, as I've mentioned, the atrial depolarization is happening in all these different directions all at once, is if you have this connection from top to bottom over here on the right, and the electrical flow goes down it, you're getting electrical signals out here before the bundle gets it out there. And so that's why you don't have that nice narrow QRS anymore, but you have that pre-excitation wave because ventricular depolarization is happening before it happens from the natural conduction system. So the pre-excitation typically reflects a right-sided pathway or a right-sided left pathway, meaning like a septal pathway over here near the right side. If it's way left posterolateral, it's gone down the bundles by the time it's gotten out here to go to the ventricle through the accessory pathway. So the EKG just simply doesn't reflect the pre-excitation. It's not that pre-excitation isn't there, it's just you don't see it. Now, we're talking about Wolff-Parkinson-White pattern when you see a delta wave. But what is Wolff-Parkinson-White syndrome? Anybody have an idea of the difference? And you know, so a lot of pediatric EPs study kids to make sure they don't have Wolff-Parkinson-White syndrome because it can be lethal. And this is the story you hear: some kid exercise and then boom, collapses. And what happens is that it's the antegrade conduction properties that can conduct A to V faster than 200, I should do this the other way, faster than 240 milliseconds. And so we test that, and the PZPs actually test it through the esophagus by pacing the heart through the esophagus. And they risk stratify these accessory pathways and show if it can't go faster than 240 milliseconds, you shouldn't be able to have an SVT or degrade into fib and then fibrillate the ventricle. But Wolff-Parkinson-White syndrome is a very rare cause of sudden cardiac death defined as an antegrade conduction across an accessory pathway of greater than 240 milliseconds. Pretty precise stuff. You got to know it from a standpoint of treating kids and being safe and keeping them from dying suddenly. Okay? We like to keep kids from dying. So that's Wolff-Parkinson-White syndrome. So Wolff-Parkinson-White, as an SVT, is really called AVRT. And that's where it goes down the normal conduction pattern, up the accessory pathway, and back around. So now you're in a micro-reentrant circuit here, an AV nodal reentrant tach, AV nodal reentrant tach, AV NRT, versus atrioventricular reentrant tach, AV. So now this is a macro reentrant circuit involving both the A and the V with going through an accessory pathway. These are the most fun to ablate because the physiology is so cool, and I like to see all the signals. If I could bring y'all into the lab one day, let you see where my brain gets all excited. But the point is you just don't get a bunch of these because this accounts for about 30% of the SVTs. So between these two, you sound pretty smart saying, I bet it's one of those two because you just got 9 out of 10 of them. Okay, good job. Now you got to figure out what to do about it. The third one is a small nest of cells called an atrial tach. And those get a little tricky because they look a lot like sinus tach. And you'll see these people come in, but most of the time, the P wave in V1 is positive because it typically comes from the left atrium. So when I said, when you saw sinus tach, what would the P wave orientation be in V1 and 2 in sinus? In V1, the P wave would be what? And in lead 2, the P wave would be what? Sinus. Coming from the top, going to the bottom. So it starts by V1, but it goes away from V1 and towards V2. So V1 will be what? Inverted or negative. And P wave in lead 2 will be positive. But in atrial tach, very often, and this is why how you can delineate sinus tach, is the P wave in V1 will be positive because it's firing up here, not here. It's going back up to V1 and towards it. You'll see some changes there. So atrial tach is a more, let me say, less common, and you tend to see this. Again, history is important in older smoker, obese, sleep apneic, hypertensive, valve disease folks that we take care of in their 60s, 70s, and 80s. So these are folks that have earned their pathology. This is typically folks that it wasn't because mom went to the party that night while she was making the baby. It's just this is how the baby formed. And these are sort of almost like natural variations of your anatomy. So, and the history is very important because in SVT, very often they'll say, this started when I was 16. And I can cough or bend over or do something, put my face in cold water, and it'll break. People will tell you this stuff if you ask well enough, and sometimes they won't. I don't know. Sometimes. The point is they'll give you a history of, usually it started in young age, sometimes can kind of take a dip through middle age, baby making years, and then kind of pick back up later in life. Atrial attack is, I've never had this, doc. And they're sitting there with their oxygen cannula. They're like, that's not SVT. That's, of these two, it's probably this. So it's important to know. And we can ferret all these mechanisms out in the EP lab with pacing maneuvers and different stuff. So what in the hell do I do for this? Get rid of the extra wire. So I can come in with a little 4-millimeter tip ablation catheter, hunt this slow pathway which lives within this anatomic area called the triangle of Koch, find the signals, and then ablate the slow pathway. It's neat, man. We're going. That means they never have it again. In this case, you go find that accessory pathway and you ablate it wherever it is. Now, the ones that live over here by the AV node, I've had to leave alone. I've mapped some to literally just right onto or right under the AV node. And so I'm like, sorry, man, it's either that or a pacemaker. Because as soon as I burn there and I damage your AV node, you'll need a pacemaker. So, 36-year-old guy don't want a pacemaker. He's like, I'm going to have to let my heart go nuts every now and then, and I'll just do my maneuvers. And so that's an unfortunate reality of the proximity to the AV node, but they certainly exist there. So ablating the accessory pathway for AVRT. And then for atrial attack, those are cool because you can typically map them down to one spot, and you burn that spot, and boom, it's gone. Sometimes, though, quite common, they'll have more than one spot. So you have, because the disease of atrial attack is not typically just focal. It's scarred and stretched throughout the entire atrium. So you have multiple foci of atrial attack. So that's SVT in a nutshell. Adenosine will terminate atrial attacks, even though it's not a circuit and doesn't have the AV node. That's more about what's happening within the cellular focus. So a termination with adenosine doesn't differentiate these three. It just says it stopped one of those three. Now you go figure out the rest. So that's SVT in a nutshell. Questions about that?
So the atrial attack is not like AFib or A-flutter.
First cousins. See, I pay him for this because then he sets me up for the segue. All right. All right. What in the hell is that? It's life. Once again, I'm giving you different ways to see life. It's not sunrises, sunsets, baby butts. It's this stuff. Okay? Cell surface signaling, the gradient we talked about. For every cellular depolarization happening 60 to 80 to 90 times a minute, over and over and over and over your whole life. We're all sitting here doing it. We're not even thinking about it. How cool is that? Our engines are running. We're not even feathering the gas on them. So the point is that what's really happening is at that cell surface with each movement is now you're causing intracellular signaling down to the calcium channels on the what? What is this? Chinese finger puzzle? Muscle. Shit, man, that's what we're talking about, right? Squeeze. So this is the juice, man. This is everything. All this other stuff we've been talking about is about making this thing go this, and this, and this, and this. And it's all because of calcium. So calcium handling within the sarcoplasmic reticulum is where we think the majority of ectopy comes from. So irregular management of calcium, boom, boom, extra beat when it wasn't told to. So it enters, fires when it wasn't signaled to and it wasn't timed out to. And the same thing kind of extrapolates out into AFib and flutter, is because now what's happening is the calcium enters and effluxes without being told to. Now it creates fibrillation. Total chaos, which is why the big shock when we cardiovert people gives just a millisecond or two enough to kind of hit the reset button and say, all the calcium efflux out of the sarcoplasmic reticulum, let's reset our top to bottom, cell surface to intracellular, cell surface to intracellular. And so that understanding that everything we've been talking about is about this functional unit of the myocardium now lets you understand that as there is dysfunction of the calcium handling is when you lead to fib, flutter, PVCs, PACs, that kind of stuff. All right? And so, I forgot how good chalk smells. Better than those damn markers. Yeah. All right, so let's talk about flutter because I think it's a good segue into understanding first cousinhood of AFib. And it's the more organized of the two atrial arrhythmias that aren't SVTs. And so typical atrial flutter has a very sort of pathognomonic EKG pattern. And you guys have seen it. You may not have even known what you were looking at. But a flutter wave is really 4 phases. If you get really, really down microscopic like we like to get with EKGs, and it has that very distinctive sawtooth pattern. Okay? And that sawtooth pattern isn't just a funny undulating wave. It's representing certain motions and movements of atrial deactivation, or activation, I should say. And so typical atrial flutter spins around the tricuspid annulus over here on the right side. Okay? And so I actually have 2 flutter ablations today waiting for me up in the lab. And so what we're going to do is I'm going to put them in the flutter, and then I'm going to prove that this is where it lives by some pacing stuff. I won't get into all that for you. But then what I can do is I can burn from the valve straight back to the inferior vena cava in a line. That's not that simple, by the way, to draw that straight line. But the point of drawing that line of scars is so that electricity can't flow in either direction at that spot. So this is like going to the Indy 500 racetrack and then a bulldozer just knocks out 10 feet of concrete. And now they can't run the race because they'll just have car wrecks all the time. So that's flutter, atrial flutter. That's, the other part about flutter, which is really cool, and how you can just differentiate it on EKG, is by looking at your RR intervals. You're going to say, wait, hold on. How do I figure out an atrial arrhythmia by looking at the ventricular depolarization? It's because those are fixed cycle lengths of typically 200 to 300 milliseconds. And so the point is that it's a reproducible interval. And so when you conduct, let's say 200 milliseconds, remember I said get comfortable with 60,000 milliseconds and dividing stuff into it. So at 200 milliseconds, that's 300 beats a minute. If the AV node didn't decrement or winky Bach, and you had one-to-one conduction of flutter and your ventricle went 300 beats a minute, what do we say that's bad for? No blood flow. You're basically fibrillating. All right? And so the point is that the AV node is protecting the ventricle from the one-to-one flutter. So the typical rate then, divide 300 by 2. Quick. Oh, damn. All right, so 150. So that's 2-to-1 AV flutter. That's 2-to-1 conduction. And so that's the neat part about the reproducibility of understanding the cycle length of the circuit itself, 200 milliseconds. And that if it has to go twice, it's 400. So 60,000 divided by 400 is 150. So your standard flutter ventricular rate when they walk into the emergency department or into your clinic tends to be about 150 beats a minute, give or take 10 beats. If you start to have variable conduction, 2-to-1 versus 3-to-1 versus 4-to-1, that's math too. So the point is that if you go 3-to-1, now you're going to be 100 beats a minute. You go to 4 to 1, you're 75 beats a minute. And so it's very predictable. And so when you look at your RR in Flutter, you should be able to say, okay, if I'm 2 to 1 on this, if I'm 3 to 1 on that, and I can reproduce those RR intervals. So that's the most critical way to delineate Flutter versus Fib. Because sometimes Fib will have, especially in V1, that real P-wave looking morphology. And you're like, oh, wait, man, is that Fib or Flutter? What's going on there? Then go look at your RRs. Sir? In Fib, they will be, that's correct. As opposed to Flutter, which they'll be regularly irregular. Remember the physical exam descriptor, regularly irregular? It's all because of math, and it's all because of the circuit. So that's the cool part about Flutter, very predictable. Flutter is like your intro EP rhythm that when you really want to get somebody drawn into EP, you bring them into a Flutter ablation, and they all of a sudden structure and things start to make sense, and they're like, wait, there's some predictability here, I can understand this. It's really, really neat. I mean, I remember that was my first ablation where I was like, wait a minute, oh, this stuff's cool. Because you can fix them. And when you fix them, the neat part is their hemodynamics improve almost instantly. So I remember one of my mentors, and I'm always gathering information. You know, when just an aside, I'll get a little philosophical on you. You guys start taking care of people the second you see them. They will wheel in through the emergency department. How many thousands of people have you sat and seen walk through that or wheeled in? And you, with your experience, I bet, can say, ooh, that one's really sick. That one's not so sick. You know, they're sick because they're at home and nobody's taking care of them. That person's sick because he does drugs. That person's sick because he smokes. He's 400 pounds. You know what I mean? So the point is you can immediately start to deduce things. This might be called profiling if we were police, but the reality is that's just what humans do. Gather information and process it to try to put together who's what. The reason to say that is you start to have to be able to walk in and take care of these various people and these various problems with some kind of a information gathering approach. And so you're always trying to gather information. And the point is you can tell a lot of what you think is going to end up happening by how they smell. Are they clean or are they dirty? You know, how well kept are they clothes-wise? That kind of stuff. So I encourage you to let yourselves be sort of in that moment all the time with these different patients. And look, you can get a lot of information about how the family dynamic is by how prevalent is the visitor? Who are the visitors? How long do they spend? How do they interact with the patient? You know, because then you got to figure out how do we take care of them when we send them out of here. So you got to start figuring that out. That may not necessarily be your job as the nurse, but it certainly is as a patient advocate where you're going to come around on rounds and say, listen, man, nobody's visited old granny here for 2 weeks. What's going on? We got to figure this out. What is our disposition? You know, stuff like that. So just be you want to be curious. This is the fun part about this job is you are rewarded for your curiosity, your intellectual curiosity, your personal curiosity, because you're trying to help this person who's come to you and said, I need help. So I encourage people to be kind of dialed into that and then get down into the molecules and the cells and stuff too. So just a little bit of an aside. All right. So that's Flutter. Very organized, very cool. I guess where I was going with that was the central venous pressure I was going to remind you of. So as I said, I'm gathering information all the time. So I get access in the femoral vein. And the first thing I do is I take the sidearm of that sheath and I raise it up to find the CVP. I don't have you transduce it on the monitor. I just have measured thousands of them. And I let the anesthesiologist know euvolemic, hypervolemic, hypovolemic, whatever. So the point is there's a ton of stuff. In Flutter, I remember the case now. We measured the CVP before the case. Abhi Samra was the guy I was doing it with. And he goes, you will love this. We will fix this patient. And so we had a CVP of like 20 when we started, and they were in Flutter. We ablated the Flutter. And he goes, now measure the CVP. And it was back down to normal. And like I said, that was the day where I knew manipulation of the electrical system was going to be my gig, because now you're really messing with hemodynamics by doing it. So really cool stuff. All right, so now let's talk about AFib. Those are disproportionately large pulmonary veins. That's okay. So these 4 circles represent the pulmonary veins that are coming from the lungs, plugging back into the heart. Okay? Where those pulmonary veins attach is not a clear connection where the vein just sticks into the atrium and then the atrium starts. It's really more like if you took saran wrap and poked your finger through it. And atrial tissue lines these pulmonary veins. So when I talk to you about understanding the anatomy and understanding how we get these pathologies, remember, this is a centimeter and a half thick ventricle. This is about a 1 millimeter thick mitral valve. And this is about a 2 to 3 millimeter thick atrium. So the point of that relationship is blood is at the highest velocity, highest pressure in the whole body, right here, 60 to 80 to 90 beats a minute. So 110, 120,000 times a day, this sucker squeezes and it pressures back on the antechamber, the atrium of the ventricle. And if you even have one little whisper of regurg, that's just one little extra burst of pressure insult to the left atrium. And just like water dripping on a rock, over years, there's going to be some stretch and there's going to be some changes. And that stretch and scar is where we really see the trouble. We just had 2 patients upstairs on the telemetry unit. There's 3 of them for a couple days, but 2 in a row. Both of them almost 400 pounds, swole up like the Stay Puft Marshmallow guy, and in fib. And we've literally had them on dobutamine and diuretics for 3 weeks. Each of them have diuresed about 30 to 40 liters. So when they came in, we tried to shock them back in normal delivery. At least one of them we did. And he went right back into fib. The lady who we just shocked after the 30 liters off has maintained normal rhythm. And it's because we reduced the stretch on the left atrium and took off some of that pressure. And it is, like I said, the pressure and stretch. I will allude to a change that happens in our lovely ladies when they have babies to their skin and these marks that they don't love. But think about that sort of, when I say gross, I mean observable anatomic manifestation, gross manifestation of stretch. The same thing happens within the atrium. There is scar and stretch in that almost same mechanism that then leads to that intracellular calcium handling that is erratic and chaotic and leads to fib and flutter. But the majority of why I mentioned these pulmonary veins arises from in and around these pulmonary veins. So what we know in regards to sequence of events of how, or sequence of approaches to ablate AFib or manage AFib is, I come in from the right side, crossing to the left, and you can either burn one spot at a time. Y'all tell me when you're tired of me drawing little circles. Yep, me too. So, point is you can burn that line of scar. It's very, very tedious, but doable. Or use the cryo balloon, which is what I've adopted for several years now. And I get contiguous contact and subsequently down to minus 55, minus 60 degrees Celsius. So we're giving purposeful frostbite to create a ring of scar. I put a ring of scar around the opening of all 4 of these vessels. And the idea is then to block the AFib signals from getting out into the rest of the heart and causing fibrillation. So the name of this first ablation is called a pulmonary vein isolation. You'll see that in my notes. I try to document that and explain what I'm doing and why. So pulmonary vein isolation is the first step in controlling AFib. Well, nature says, oh, that's clever, but now watch this. And it will start to spin electricity around the scar that you've put in, or around here. So this is starting to get kind of chaotic. But the next step then is to make sure the veins are isolated, then give a roof line and a line of block here, down to the mitral valve. This is adopting essentially a maze, surgical maze approach. So the surgeons are the ones who did AFib ablations first. Start back in, I want to say like maybe the 60s or 70s, where they started scarring the posterior left atrial wall. Well, then we started saying, well, maybe we don't have to crack your chest open to do this. Let's figure out how to do it from inside the heart. And that's where the 90s come in. And then now, really, essentially, since about 2000, we're trying to make this more standardized. And the energy sources that we deliver and create the scar with are evolving. Really cool stuff. I could get nerdy on the technologic side of what we're doing with energy. There's a new modality called pulse field ablation that's coming out. But anyway, point is how we're learning to manipulate this tissue to create the scar is evolving and refining and becoming safer and more efficacious. It's really pretty cool stuff. And so that's AFib in a nutshell from an ablation standpoint. Now, once I've done that second ablation, we don't know what else to do next from an ablation standpoint. And so the point is that there'll be guys who say, oh, you got to consolidate the scar. Oh, you got to isolate the posterior left atrial wall, all this stuff. Point is the panel of international experts at the AFib meeting every year agree. Step 1, isolate the veins. Step 2, re-isolate them, add these extra lines of scar. Step 3, that's when they start arguing. So then very often what I do, you'll see this sometimes, put the pacemaker in, try to do by V, and then I ablate the AV node. And in doing so, you've accepted fate. You've lost the battle. AFib will reign in the atria for the rest of their lives. But now with the AV node ablation, they can't talk to the bottom chamber, so you take over with the pacemaker. And it gives regular ventricular squeeze instead of. So that's kind of last step to treat AFib from an ablation standpoint. And you'll see multiple different medicines and all sorts of different things people are trying to do sort of in the interim or adjunctive to the ablations. But when you get to the end, the BIV pacemaker or pacemaker with an AV node is kind of your last step.
When you have a pacemaker and you say ventricular pace, and you say the underlying rhythm,
Sometimes, because what you're seeing this. You're seeing a paced beat, we'll just say, and in the background you're not seeing any atrial pacing. So if you have a ventricular, let's say you have dual chamber pacemaker and you go in a fib, the pacemaker has something called mode switch, where it says, ooh man, something's going on over in that top chamber. They told me not to pay attention to that. I'm going to ignore that, so I'll just beat down on the bottom chamber at a set rate. So mode switch, and someone without an AV node, it defaults to a base ventricular rate. And those are typically pretty predictable by company. So Medtronic tends to be 80, Biotronic tends to be 70. So, there's some little things, but you can reprogram that too. So there's a lot to that. So when you see someone in AFib with just ventricular paced, they probably don't have an AV node because there's not a ton of those walking around. They probably just mode switched into a baseline ventricular pacing mode. So, go ahead.
So you see patients in their history that have had ablations in the past, but they're still in AFib or something. They just haven't gotten to this point of the ablation yet?
Yeah, it's tough for me to answer that, but most of the time, we haven't gotten to the point where we.
If you do that, then it should be done.
Now you're totally dependent on the ventricular pacemaker. And when you say it should be done, the point is you'll just never go too fast again. But there's some people, for example, who have chronic atrial fibrillation and they're bradycardic. So we just put a single chamber device down in there and we say, look, even though you have 300, 600 beats a minute going up here, you're running in the 40s. So here's your ventricular device. You don't need an AV node because now it'll just pace regularly for you. There's one last little pacemaker to mention to you that's a new thing called a Micra. And you're going to see more and more of leadless pacemakers coming in the future. They're really cool. But it's that might have been one of my ladies. I don't know. But yeah, we definitely come across that. But the issue is that they haven't quite figured out how to give me a dual chamber device to give me AV synchrony. And we go way into the technology here. It's really cool stuff. But bottom line is I started my career doing one thing, and over the next 17 to 20 years, I think I'm going to finish up my career doing something I'd never started doing before with little pills here, there, and everywhere. So the technology continues to shrink and refine And so we're gonna get to a point where you're not gonna see leads and a silver dollar sitting in somebody's chest. It's gonna be that pill out in the ventricle.
Yeah, this guy, it was just this week, he had an allergy to titanium, and apparently all pacemakers are covered in titanium.
Yeah.
So that was his only option. And I believe it's inside the right vent.
Yeah, so we had one young lady who had developed a titanium allergy, and Medtronic actually made a gold-coated pacemaker.
Said the wait list, I mean, it takes weeks to
It does.
order it.
Yeah. And then she got infected because of a port and got bacteremic, and I had to take the device out. So, like I said, start gathering information the second you see your patient. They reel in the room, you walk in the room, you're looking, you're smelling, you're talking, you're listening. You want to do all of what we do at a very high level, but you're also a person and they're a person. And so all this stuff you got to have in the back of your head. And the reason I mention that is I used to teach as a chief, it's from the handshake to the molecule. Well, one of the EP guys who published a textbook said from the bedside to the cell. Oh, fine, all right. You published the textbook, now you got your phrase. But the point is that we ought to be having what's happening at the molecular and cellular level in our heads while you're saying, welcome here, Mrs. Johnson. We're going to take good care of you. Don't worry. Everything's going to be okay. What's wrong? How'd you get here? Whatever. So you got to have this stuff, and you got to have some of this stuff while you take care of these folks. All right. Any other questions? Yeah, so it's if they are symptomatic and you can't control the ventricular regular rate. So if they're not chronic bradycardia, you can't just put a pacemaker and give them 60 beats a minute. So, you'll get these folks, they'll come in and they'll be 110 beats a minute and they're on amio and cardizem and toprol. Part of the management of the atrial arrhythmia is flutter fib, specifically fib. And we've moved a lot more into understanding of maintenance normal sinus rhythm, specifically as it pertains to heart failure, is better. But sometimes if you just can't win and you need the regular ventricular squeeze to help you, that's when you move to the AV node. It's if there's too much ventricular irregularity. And so I get in arguments with some of the other cardiologists who have an older concept of what that's for, only if they're too fast. Yeah, but I've seen slow and irregular also be inefficient. And so I think the bottom line is if you're still symptomatic because you're in fib, despite having done all these previous ablations, that's when it's time to consider the pacemaker implant with the AV node. You wanted me to do a Watchman ad? Is that what it was?
So tell me what the hell a Watchman is, because I don't know what that is.
I'll do it and we'll wrap up. All right, so. Well, I promise you they're not going to be ready for me to stick at 10. That's me taking a dig at the cath lab. Okay, so this that's not a dirty drawing. This is the left atrial appendage. You have a right atrial appendage. And just like the gallbladder and the appendix, we're not really sure why. It doesn't really serve much of a function except for to cause freaking trouble. All right? So imagine now, I've described multiple times kind of this quivering, fibrillating atrium. And now you got this windsock sitting out on the side of this thing. Well, that damn thing's sitting there wiggling around too, And so if you think about what's happening hemodynamically, and we see it doing TEEs, and especially if you've been in the ICU and done a TE with me and I said, hey, look, there's smoke. What you can see is the blood swirling slowly and inefficiently, and you'll see it wisping down through this appendage. So we know as of the mid-late 90s when we started to really develop ultrasound, I'm going to give a little history and then give you how we got here. Mid-late 90s, we develop echo, or early 90s is echo, and it's all in one line. But then we figured out, oh, wait, if we put a bunch of those lines together, we get an ultrasound picture. And we get our ultrasound picture is in a fan, in a single plane. And so as you turn the probe, the fan turns. And so that's how you build your 3D anatomy, is by these 2D images over and over and over in different angles. they started doing TEE. So they put the probe down the esophagus, and the esophagus sits right behind the left atrium. And so now our window is looking into here, and we can see the atrial and valvular structures a lot better. So when we started to do that, we started to say, when we see clots, we tend to see them in this appendage. So then I'm sure some cardiologists said, hey man, we got this new thing, we keep seeing clots down here, and talking to their surgeons. Hey, while you got the chest open, can you cut that thing off for me? So they started to do it in different places, and then they tried to organize some trials, and they showed that if they did a left atrial appendage ligation and cut that thing off or sewed it over, that people didn't have the same risk of stroke when they had AFib or flutter after that, when that appendage was missing. So then they said, whoo, okay, you know, it's the 2000s, we're getting kind of endovascular. Let's start figuring out a way to do this from inside of the heart instead of having to crack people open and cut that thing off. So a bunch of little biomedical engineers sitting there, probably funded well by some industry, comes up with a couple of different ideas. There was the lariat, there was different things to try to either say, can I go inside without cracking the chest open and cut this thing off, or can I plug that hole somehow? All right, so the Watchman's first iteration looked like this. It was a basket of metal tines that had these kind of like points out at the top, but the thing smashes down, and it's about the size of a quarter. It's like stacking 3 or 4 quarters up. So just kind of get that in your head on size-wise, but you can smash it down flat. I can introduce it from a sheath about the size of a shake straw, from the vein here on the right side and into the left. And then we can deliver it into this appendage, and when we put it in there and it deploys, now you've got this fibrous, there's a fabric, some kind of fabric over the top. And so that you put that right here. And the point is that now plugs that appendage. And over time, like any foreign body, the heart identifies that as, that's not from me, and it'll grow a sheet of scar tissue over the top. And in doing so, by having that foreign object in there, and now you grow a sheet of scar tissue over the top, you've occluded the left atrial appendage. You didn't ligate it, you didn't cut it off, you occluded it. And so surgical ligation, if you're going to have a bypass, always talk to the surgeon like, hey man, let's just cut that thing off for me. Now they don't like that because that's another hole that can bleed. So they're, you know, I miss Chuck and Jose, and God rest Chuck. But he was a smart dude, and he knew how to take care of patients the way I'm telling you to take care of them, because he gave a shit. And he always knew to ask, hey, should I go ahead and do that? Because I know that's going to help people. And so he did a ton of those ligations for me. But now we've got this Watchman device. And so the new iteration is they close this basket in so the thing is completely atraumatic. So it creates this little bubble of metal mesh, and you can kind of push it against tissue, and it's real soft. It's not poking things. And so now, like I said, we just plant it in that left atrial appendage, and it occludes it.
Basically, the Watchman is replacing, I can't remember the term, but I want to remember it, but I remember we would run something up the inferior cave and put a basket there, and there for somebody to talk to John.
No. So inferior vena cava is more about blocking DVTs from getting to the right side of the heart. The Gunther tulip or the IVC filter. Yeah. So, and look, we don't like putting those in because people will forget about them, and then they'll have occlusions and collateralization and all sorts of bad stuff. So, I mean, they're helpful when you need them, but that's more for DVT. So it doesn't PE, you know. This is so that you don't form where 90 to 95% of the clots form in the heart. You can't form them there anymore. So the protection of a Watchman or a left atrial appendage ligation, surgical removal, versus plugging it with this thing is as good, if not better, than using Eliquis, Pradaxa, Coumadin, and that stuff from preventing stroke. So this is a very, very powerful modality to be able to offer people.
If you get that, you won't be on Eliquis?
The day you go home, you're off those blood thinners. It is. It used to be 6 months of staying on it, but the Europeans pushed the envelope for us and had the data for the FDA to finally say, okay, you're right, we can do it. So as of September last year, the day we implant it, you're off the NOACs and the Coumadin, and you're on aspirin Plavix for 6 months. And then at 6 months is when we can drop you to just aspirin. And so now here's little Granny Jane walking around in her cane, just on an aspirin instead of, ooh, wrap her in bubble wrap, please don't fall. So it's really, really been a neat thing to be able to offer patients. If it did, this is where I take another jab at my lung doctor friends. You've got these wonderful filters called lungs that'll keep that thing from going off and causing a stroke or occluding the kidney or your toe or your gut. You know, so yes, PEs are bad. I'm not saying they're not. But if one forms in the right atrial appendage, it'll go to the lungs, unless, just for fun, you've got a PFO or an ASD and you have a paradoxical emboli. That's just a little curveball nature likes to throw us, like, oh wait, you forgot about that hole in your heart. Now DVT comes and slips over into the left atrium and thump, off to causing trouble. Yeah, but typically no, go to the lungs and then be less of a arterial occlusion process. You know. All right, guys. Any other questions? Well, thank you for your time. Good questions. You got it. I appreciate it.